All right, good evening, everyone, and thank you for joining us for tonight's Musculoskeletal Health Australia webinar. Our topic tonight is fibromyalgia and managing brain fog and fatigue. My name is Bella Fitzgibbon, and I'm a member of the MHA team. Firstly, before we get started, I would like to take this opportunity to acknowledge the traditional owners of all the lands from which we are joining the webinar this evening. Musculoskeletal Health Australia is bringing this webinar to you from the lands of the Eastern Kulin Nation, and we pay our respects to the Boonwurrung, Bunurong and Wurundjeri peoples as the traditional owners and custodians of these lands. We acknowledge and uphold the traditional owners' continuing relationship to the land and waterways and pay our respects to their elders past, present and emerging. Before we get started this evening, I'll just run through some housekeeping. So we'll have the chat open throughout the webinar. I will monitor this chat. Please feel free to put any questions or comments in the chat, and we'll endeavour to answer all of these in our Q&A part at the end of this webinar. This webinar has raised any questions or concerns. Please make sure you call the Musculoskeletal Health Australia Back Pain, Arthritis and Musculoskeletal Helpline, which we like to refer to as the BAM helpline. I'll read that number out now, but feel free to put a message in the chat if you'd like me to post it there. So the number is 1-800-263-265, and we have some highly qualified healthcare professionals on that helpline ready for you. For tonight's webinar, we are going to delve into the complex world of fibromyalgia. More specifically, we are exploring how we can empower ourselves to manage the brain fog and fatigue that is associated with living with fibromyalgia. We are extremely fortunate to be joined this evening by Dr. Emma Guymer. Emma is a rheumatologist and head of the Fibromyalgia Clinic at Monash Medical Centre in Clayton and the General Rheumatology Clinic at Dandenong Hospital. Having graduated from Monash Uni, she trained in rheumatology at Monash Medical Centre and the Alfred Hospital in Melbourne. She then undertook a research fellowship in fibromyalgia at the Georgetown University Medical Centre in Washington, D.C., USA. Emma has an incredible track record in general rheumatology and fibromyalgia clinical care and fibromyalgia research via Monash Health and Monash University. At MHA, we can't think of anyone more qualified or experienced to take us through this topic this evening. So on behalf of Musculoskeletal Health Australia, we welcome you, Emma, and we'll throw over to you to get started into this presentation.
Well, thanks very much, Bella. That's a bit of a whopping introduction. Thank you, very kind. Let me just share my screen. Can you see that?
Yeah, that's perfect.
Yep, that's good. All right, and I'll get rid of that little squarey thing. All right, and once again, thanks very much for having me along. Hope you're all, if you're in Melbourne and it's sweltering, I hope you've got some aircon or staying cool somehow. And nice to be here to talk about fibromyalgia and some aspects of management and fatigue and brain fog in particular. So what I thought we'd go through is what fibromyalgia actually is, why does it occur, the clinical features of fibromyalgia and how we diagnose it, the general management principles of fibromyalgia, and then I'll talk a little bit about fatigue and brain fog too, since we're going to discuss those aspects of fibromyalgia that are generally very tricky to deal with. So first up, what is fibromyalgia? Well, fibromyalgia is a clinical condition that is characterised by widespread musculoskeletal nociplastic pain. And when I say nociplastic pain, this is a term that refers to pain that occurs due to altered processing of pain signals, where there's no actual or threatened damage of tissues in the body, and there's no disorder in the pain sensory system itself. It results in a situation where there's increased central nervous system sensitivity, and it goes along, it sort of has the other associated features that also come with increased central sensitivity, and we'll talk about those in a minute. affects 2 to 4% of the population is generally what is stated. However, about 10% of the population worldwide reports chronic pain, and there is definitely certainly a level of people out there who remain undiagnosed. It does occur more often in women than men. We used to think that that difference was very large, sometimes up to 7 to 9 times more women than men. However, we now understand that with more nuanced diagnostic criteria, that it's probably about 2 times the number of women than men experience fibromyalgia, and this is probably relates to a lot of genetic factors, and we certainly know that women's general pain thresholds not as high as men. So there's quite a few factors involved. Fibromyalgia can occur by itself, but it also can occur together with other chronic disease, and there are many people who have chronic illness such as diabetes or rheumatoid arthritis or lupus or thyroid conditions who also have fibromyalgia, and we'll talk a little bit about how that happens, but it's generally due to stress occurring in physical stressors occurring in your body, contributing to that enhanced stress process. So the clinical features of fibromyalgia is chronic pain, so more than 3 months of widespread bodily pain. And then there are other variable features of that come along with increased central sensitivity. We call these central sensitivity symptoms. Fatigue is almost ubiquitous, stiffness, poor quality, unrefreshing sleep, cognitive disturbance, which we refer to sometimes as brain fog or fibro fog, which is pretty much difficulties in the area of memory, attention, and information processing speed. Tingling, pins and needles, odd sensations in different parts of the body, autonomic dysfunction, which relates to heart rate variability, blood pressure, those sorts of things, and increased sensory sensitivity for all other sensations. So what we really think is going on is that all humans have a level of how sensitive we are to our external environment. We call this how sensitive our central nervous system is. So we call this central sensitivity. I don't know whether you can see my little arrow there. And we all exist on a scale of how sensitive we are to incoming messages from our surroundings. So down here is low central sensitivity, and up here is high central sensitivity, up this end of the scale. And right up this very end, we are so sensitive to the incoming messages from our environment, we experience them in the painful range. And that's what that fibromyalgia really essentially is. It's, and you can call it all sorts of things. You can call it, increased central sensitivity with widespread musculoskeletal pain if you want to. I like fibromyalgia. It's just one word, and it's very clearly defined, and we have a lot of reasons to know exactly what that means from a research point of view as well. So we are all on this scale at any one point in time, and we have a sort of a set point or a start point, if you like, where it's our base level, and everybody's is individual, and it is determined by partly by our genetics and partly by previous experience, and often early life experience, perhaps childhood adversity or stressors that occur before someone's developed adequate coping mechanisms. And this is our set point is basically somewhere on this scale. And then over the course of the day or week or months, we slide up this scale when there's increased stress hormone released in our central nervous system, in our brain. We slide up this scale, and then we slide back down when that settles down. When we've overcome the stress, or we've managed to effectively manage it. Now, that's fine if your set point's down here and you slide up this amount and you slide back down that amount. But if your set point is further up and you slide up even the same amount, you can go right up into this end where you're experiencing everything in that super sensitized range, and it is represented by painful sensation. So the aim of therapy, in a nutshell, and we'll talk it through in more detail later, but is basically to try and keep people down below this dotted line as much as possible. So amplified sensations in fibromyalgia are very much part of the condition. So there's pain, as we've talked about. There's pins and needles or numbness or odd sensations like ants crawling or all sorts of different things that are felt all over the body at different times sometimes. They come and go a bit. Sometimes they're there permanently. Tinnitus or ringing in the ears. Bowel and bladder sensations. We're not used to feeling the food being pushed through our bowel or our bladder filling up, but when you've got increased sensitivity and you feel everything in a much more sensitive way, you suddenly become aware of those sensations, and they can be represented in the painful range. Dizziness, palpitations occur, particularly when you're standing up, as I was referring to those autonomic issues. You're sensitive to loud noise, bright lights, strong smells. It's where's the sunglasses, turn the TV down, that sort of increased sensitivity. You're sensitive to chemicals, and this can include medication. So it's not just paint, perfume, petrol, but it can be side effects with medicines, even at quite low doses. So quite simply, the volume dial is turned up on all the sensory experience. There are associated conditions that come along with fibromyalgia. They're very much bound together in the same patient groups, and many of these relate to underlying increased central sensitization. Depression and anxiety are big features, and in fact, we'll talk a little bit more about depression down the track, but headache, recurrent headaches, irritable bowel, irritable bladder, interstitial cystitis, chronic sinus pain, temporomandibular joint problems, pain particularly, multiple chemical sensitivities, as I've referred to, pelvic pain, vulvodynia, restless leg syndrome, hypermobility, and POTS syndrome are also all associated with fibromyalgia. So this is one way of thinking of it, that all these different syndromes that are have a basis of increased central sensitivity all have slightly different flavours to their symptom profile, if you like. So irritable bowel syndrome versus chronic fatigue syndrome versus regional pain, but they're all overlapping. And I guess the best way to think about fibromyalgia is possibly sitting in the middle where all of these intersect. But basically, all of these conditions are under that increased central sensitivity umbrella. So you can have a situation where you've got, I don't know whether you can see my arrow or not. Oh, there it is. You've got these four key features that pretty much occur in most people. And then you've got these other sort of peripheral things that may or may not be part of your own personal cocktail of symptom profile. So someone who has irritable bowel and headaches and restless legs, plus the widespread pain, fatigue, sleep, and cognition issues, will have a diagnosis of fibromyalgia. Someone else who has all of those features but doesn't have the headache or irritable bowel, restless legs, they still have fibromyalgia. And this person over here, they also have fibromyalgia. They have these key features of pain, sleep, fatigue, memory, concentration, and they also have the temporomandibular joint pain as well. You can also have this same set of clinical features, but if you have without the pain, but you have the autonomic problems, then you might get a POTS label. Or if you have this one over here without the pain, but you have the bowel issues, you still have the fatigue and sleep and memory and concentration, then you might get an irritable bowel syndrome diagnosis. But it's all under the same umbrella. It's all similar. So the way we diagnose fibromyalgia is with the American College of Rheumatology diagnostic criteria. They were initially published in 2010, slightly modified in 2011, and then they were validated for patient report as opposed to the doctors answering the questions in 2016. So they're essentially all the same group of criteria. And really what they measure with two separate scores. They measure how widespread someone's chronic musculoskeletal pain is. And then they measure the level of other central sensitivity symptoms, other pain, fatigue, headache, etc. So why does fibromyalgia develop? Well, first of all, we feel people have a genetic susceptibility. So we certainly know that first-degree relatives of people with fibromyalgia are more likely to develop fibromyalgia or other chronic pain. And we think about 50% of the risk of developing fibromyalgia and related conditions is genetic. And this harks back to a lot of twin studies done probably more than 10 years ago now. There are many different genes that we've found that are associated with the development of fibromyalgia. There's been an awful lot of work in here. There's not one fibromyalgia gene per se, but there's many different ones that are associated with the development of fibromyalgia and increased central sensitivity in general. And most of these relate to the function of certain neurotransmitters, which are chemicals in the brain that carry messages along the pain pathways. So someone has a predisposition, and then there's generally something that triggers the development of full-blown fibromyalgia. Now, sometimes you can go back into someone's history and you can talk to them and say, well, look, I've always had pain. Since I was a child, I can remember I was the one that had growing pains, and when I went through, when I got my period, I always had bad period pains, and I had bad migraine, and I had back pain. And so, you get a sense that someone's developed chronic pain quite early, but then sometimes there's a particular trigger that sort of tips them over into that more widespread pain, plus the fatigue and other things. And that sort of trigger is some sort of stressor on someone, either a physical stressor or a psychological stressor. So it could be an illness, it could be an infection. A lot of people will talk to about a glandular fever or COVID or some other sort of infection where they get over the infection, but the pain that started while they're unwell, or the fatigue that started while they're unwell, has continued, or the brain fog, or whatever the features are. Trauma, so an accident, and that can be physical or mental trauma, although it's very difficult to have a physical trauma without there being some sort of psychological impact as well. It can be a prolonged period or a difficult period of psychological stress. Or in some people, and this is a little bit more common in older people, is when there's a peripheral pain focus. So if someone has bad osteoarthritis in their back or their knees or their hips or somewhere, and there's constant peripheral pain feeding into the pain system, this can cause someone to develop more widespread pain and central sensitivity. So it can be what you might read in some of the literature, top down from a stressful situation, allowing the fibromyalgia to develop from a permissive situation, or it can be bottom up, if you like, from an injury or a peripheral pain focus that has continued to fire up that pain system, so it's not allowed to settle down. So what is happening is that, once again, I'm hoping you can see my little arrow. So the stimulus is stimulus. So something happens to the body. This is a piece of skin. Looks a bit weird with all the squiggly bits. Those are hairs. But a message is picked up in the skin by receptors, and this message is sent along peripheral nerves to a spinal cord. This is a cross section of a spinal cord, to an area called the dorsal horn. And sorry, getting more arrows than I need for a minute. And then from here, the dorsal horn acts a bit like an old-fashioned telephone exchange. It sort of decides which pathway of the spinal cord that message needs to be sent. So if it's pressure or temperature change or joint position or whatever type of information it is, it gets sent up the appropriate pathway. And if it's pain, it gets sent up the pain pathways into the brain. And once it gets into the brain, it goes via the goes via the thalamus and out into the somatosensory cortex, which is the sort of higher up in the brain, if you like. And here it interacts with lots of other processes and cognitive and emotional centres. And what happens there in that situation is, if there's a large amount of information coming up from those pain pathways, then there's amplification of the messages. In fibromyalgia, there's spread of cerebral activation, there's more widespread brain region activation, and this generally recruits a lot of other types of systems, if you like, and alterations begin in all sorts of different ways. And we'll talk about that in a second. But there's greater connections between lots and lots of different brain networks that are associated with pain perception and awareness. And there's reduced connections between some of the centres in the brain that are supposed to reduce pain or calm it down. So the pain pathways sort of get larger and more robust, and the pathways and the networks that are supposed to calm pain down fade a little bit. And then once you're up in that central nervous system in those higher layers, there's influence of stress-activated processes and emotional and cognitive centres that further modify that pain experience. So then you have a situation, again, I get my arrow out, you also have part of the way that the brain functions and controls how much of these messages are flowing up the pain pathways in the spinal cord, is to have what we call a pain break, or a descending pain modulation effect, that where neurotransmitters or chemicals that carry messages in the nervous system exert a sort of an inhibitory control on how much of this messaging is going northwards. And in fibromyalgia, these the neurotransmitters that are involved in this downwards pain inhibition are serotonin, noradrenaline, and others that are the ones that are involved in those genetic polymorphisms I was talking about before. So they're less able to perform this function because of genetic changes, which is where that genetic element comes in. So not only is the whole thing turned on and it's ramped up here, but the sort of the natural pain break, that thing that tempers how much of this central sensitization gets up and running, is less effective than it should be in many people. So I've put this in, which is very old research, but I still think it's really important. This is some of the earliest research from 2002 done by Rick Gracely and team, which really showed to us that there were real changes in the brain that were definite, they were reproducible, and people's brains were functioning, their pain systems were functioning differently to people without fibromyalgia. And these next two slides will be a little summary of what they did. But the bottom line is that they put people in an MRI scanner, a functional MRI scanner, and they squashed their thumbs. They put a stopper on their thumbnail and pushed it down with different pressures. And the people who had fibromyalgia, so there was normal controls without fibromyalgia, and there were people with fibromyalgia. The people with fibromyalgia who had thumb pressure that was really not very intense still had pain. And when that happened, these red areas lit up. Then when they put people without fibromyalgia and gave them the same amount of light pressure, they didn't light up those areas and they didn't experience pain. But when the pressure was increased until they reached a similar level of pain, all of a sudden they lit up many of those areas as well. So it was equally painful, but the pressure was different, and it had comparable brain activation, which was some of the earliest change that we saw on some of these functional MRI scans, which was really exciting. This is that same set of experiments, and you can see it represented in a different way here. So I've got my little mouse. But down here, this is the people who did not have fibromyalgia, and when there was a light pressure on their thumb, they did not have pain. But, and this along the bottom here is how much pressure was put on their thumb. But at a similar level of pressure, the people with fibromyalgia had a much higher pain intensity. And to reach that same high pain intensity, the people without fibromyalgia required a much larger amount of pressure. So this was proof that there was real pain at lower levels of stimulus and that the brain centres were lighting up in similar ways with similar lines of pain. So other changes happen when those pain pathways interact with the higher centres in the central nervous system. There's a disruption of that deep layer of restorative stage 4 non-REM sleep. So every time your brain starts to drift down to those lower, deeper levels of restorative sleep, where you get the real rest, there's these little alpha delta spikes that haul you back up into the lighter layers. So you never get down to those really deep layers of restorative sleep. There's abnormal activation of the systems that are the main neurotransmitter and neuroendocrine response systems to stress in the brain. So it's abnormally activated. So these stress responses are going off all the time. It's that fight or flight sense of everything's ready and on edge. And other organ systems can be involved. For instance, if there's increased permeability in the gut and release of inflammatory mediators into the bloodstream, which find their way up to the central nervous system and again act as a systemic stress response, increasing that central sensitivity. And you get quite, as we talked about before, quite sort of prominent autonomic features, particularly when people stand up quickly. So there are other changes. There's changes of peripheral and central neuroinflammation. There's release of inflammatory chemicals in the central nervous system and also peripherally. There's increased skin blood flow and blood vessel permeability in and around the periphery. There's microglial cell activation in the central nervous system, which again displays sort of releases. There's release of inflammatory chemicals in and around the central nervous system. And there's some autoimmune changes in that central nervous system as well around the glial cells. We know that there's small peripheral nerve fibre abnormalities, both in the cornea and skin, where the number, structure and function of these fine nerve fibre endings is impaired in about half of the people with fibromyalgia. And there's lots of theories about exactly what's going on there, but there's no proof of whether this is the chicken or the egg, so to speak, whether these are changes occurring because of the neuroinflammation or for another reason. There's peripheral changes that you can see. People often say, well, look, other than the tenderness, there's not much as far as physical features of fibromyalgia that people can see when they're being examined or see by their family and friends. But that dermatographia, and you can see a nice picture of it here, where there's the wheel and where the skin is lightly stroked, and there's that wheel and flare response, that red raised wheel, or sometimes you might get it if your seatbelt's rubbing on your neck or other places where there's that inflammatory change that occurs under the skin. There's livedo reticularis, which is like that sort of vascular chicken wiry looking pattern that can occur on the skin, particularly in the limbs. Raynaud's phenomenon, where the fingers go, fingers or toes can go white with some restriction of blood flow. And there can be peripheral swelling. People will often come in and say, look, I can't fit my rings on and my feet are swelling up. So how do we manage fibromyalgia? We know an awful lot about fibromyalgia. We know a lot about how it occurs, why it occurs. And this has been the tricky thing, because there's so many pieces of the jigsaw puzzle as to how and why fibromyalgia is occurring. It's very difficult. There's no one switch to turn off. We do have variable results even from proven therapies, because there are external factors always feeding into physical or psychological stressors that keep this stress response charging along. There's also difficulty tolerating a lot of the therapies, whether it's the pharmacological therapies, the medicines, or whether it's the other non-pharmacological therapies, but they're sometimes difficult for people to take or use long term. We always get best results with a multidisciplinary approach to management. There's absolutely no question about that. But the good news is that we have been able to show that at least a moderate reduction in pain levels does definitely help sleep, mood, anxiety, function, quality of life, ability to get to work, and all of those things that make life, and let people get on with what they really want to do with their world. So basic principles of fibromyalgia management, obviously learning and understanding about what it is and why it's occurring, how it's occurring, what are the dimensions of it, what it can affect. It's not just pain. It can affect someone in so many different ways. What are the principles to management, and also how with the fluctuations of fibromyalgia over time, is it going to look for the future? This is not a disease with a cure. This is part of how somebody is. It's part of how their central nervous system is responding to the environment, and we're all of us on this scale at any one point in time. And so the fluctuations over time, when there's increased stress, or there's it can be physical stress as well. It can be jet lag. It can be good stress. You go out for a friend's birthday party and you stay out late because you're having a good time, but then the next morning you're going to feel worse, or an anesthetic, or a cold or a flu or a vaccination, or there's so many different ways to stress the system. It's not just a big psychological stress, or it's all these little things that life throws at us. So that learning to sort of roll with it a little bit, pacing things and planning things is essential. One of the things I do say to people is that nobody gets better without doing exercise, and a regular daily movement practice is essential. And I'll talk a little bit about exercise and fatigue and brain fog in a minute, but most of the research in fibromyalgia is really around pain response. And we know that fibromyalgia pain improves with graded, gentle, and by graded I mean starting very small and building up very slowly over time, but aerobic levels. So it doesn't have to be hardcore running or an aerobics class or anything else, just enough to raise the heart rate and the breathing rate, which in people who haven't done much exercise recently is really just gentle walking. But walking is the most, accessible way to exercise. You just can go out your front door, or you can go around your backyard, or you can walk around in your living room, or you can get an exercise bike inside if it's too cold to go out, or a little pedaling machine, or there's so many different things you can do. But walking is one of the most accessible ones, and you can pick little ways to do that. I'm going to go to the neighbour's letterbox today and back. So you can start that small and that slow. Now I'm going to go to 3 more houses down and back, and then in a week later you can go to 4 more houses down. Building it up very slow is essential. I love warm pool exercise just because it takes the weight off all your joints, and it takes the ouch out of your muscles, and you can really stretch out. You don't have to swim. Just gentle water walking or wallowing around in a warm pool is enough to raise your heart rate. I think the biggest thing is to remember not to overdo it. Overdoing things can sometimes put you into a flare, and that's no good. So starting very gently and slowly. Building slowly up to about 20 minutes, 3 to 5 times a week would be what you aim for. And this is general fibromyalgia management targeting pain. Psychological strategies. I think the most studied pain management psychology is cognitive behaviour therapy, and this is done with a trained therapist. There's a definite proven benefit with tailored programs for pain, and it encompasses a whole lot of things: relaxation, pacing, goal setting, coping strategies, whole lots of things. It is tricky, however, with accessibility. You've got to find a therapist, you've got to afford a therapist, you've got to get to a therapist. There's waiting lists. There's lots of aspects to this that make it difficult for people to get to at times. But even straightforward strategies, practicing mindfulness and meditation and other pain management therapies along those lines, really essential. And doing those sorts of things every day is such a help. It's hard to learn to meditate. All these things, it's hard to learn. It's hard to begin, because the first 5 or 6 times you're doing it, you're sitting there thinking, oh my God, I forgot to get that at Woolworths, and I've got to ring so-and-so back, and tick, 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 tick. All of those sorts of things, that life is ticking away in your brain. It's a learned skill, and you've got to stick at it. But gee, it's effective. As our mind-body practices, so Tai Chi, Qigong, yoga, those sorts of things, really essential. And if they're too much to do straight up, you can get them up on YouTube at home and do beautiful chair yoga, just gentle, do it within your limits. It's wonderful, but gee, they're really helpful as well. So other things, massage, myotherapy, acupuncture, other things, whatever. There's very few things that I sort of don't tell people to avoid, but just make sure it suits you. There's no point doing something that makes you feel worse and costs you lots of money, or provides no benefit. You've got to really source the things that you find useful, helpful, achievable, and you can engage with. And other stressful, don't underestimate what life's throwing at you and how much that's impacting. So relationships, home, work, finances, all of this sort of stuff comes in to add to those stress responses and make things much more difficult to work your way through. Medicines never help very much unless they're part of this general multidisciplinary plan. And so we are talking about gentle movement practice plus mindfulness, meditation, stress reduction. And your stress reduction might be colouring in, it might be listening to music, but you've got to find a way to get there, to achieve it. There's lots of different ways. You've just got to keep looking. Medication, we do start with very low doses because people do have those chemical sensitivity tendencies, and then build gradually. And at best, we generally have this 30-50 rule, where 30% of people feel 50% less pain and 50% of people feel 30% less pain. So none of these are really good on their own. You've got to add them into these multidisciplinary sort of strategies in order for them to be more effective for that. Now, simple pain relief is something that everybody's tried well before they've ever seen a healthcare professional about their pain. But certainly for some people, paracetamol, anti-inflammatories do help, particularly if they take them before they're about to go for their walk, or to help with breakthrough symptoms and things. We can talk about, the opioid. These are, I'll talk about the opioids in a second, but these tramadol and tapentadol are non-typical or atypical opioids, and they have an aspect to their chemical makeup that means they act a little bit more like some of the serotonin or adrenaline reuptake inhibitors rather than an opioid, and that's more helpful, I think, in fibromyalgia. So these serotonin noradrenaline reuptake inhibitors, or SNRIs, they're medicines that are marketed as antidepressants in Australia, but that is because they increase serotonin and noradrenaline in the central nervous system, which happens in the parts of the brain that deal with mood. So they act as antidepressants. We don't use them that way. We use them to manage the pain by increasing, again, I'll get my little arrow going. See this big fat red line, this downwards pain inhibition, this downwards pain brake to try and put a smother on how much of these pain signals are going up towards the brain. And that's their role. That's how they work. So the ones that most people come in contact with are amitriptyline or Endep. Now, at higher doses, it's used as an antidepressant. We only use it in very small doses, usually if it's just for fibromyalgia features. Duloxetine is another one that a lot of people come across, and it's good for depression and anxiety as well, but it certainly does help pain. Milnacipran is used to be called Johnsia here in Australia. They've now stopped marketing in Australia. It's actually the only drug that Australia's TGA has approved to be marketed in the management of fibromyalgia, which is really unfortunate given that it's not easily available. It can be imported in with an SSAB form through your doctor, but it's difficult and very often it doesn't necessarily give you much greater benefit than the duloxetine, which is a similar type of medicine. Membrane stabilizing medications, the gabapentinoids, the alpha delta ligands is another way that they are described. They were developed as anti-epilepsy medicines, and they basically reduce the excitability of nerves along those pain pathways and slow those impulses along the pain pathways. Lyrica is the one that's used often. I prefer much smaller doses than is in the literature, and gabapentin can also be used. Slightly more significant side effects with that one sometimes, but they reduce that nerve excitability, and they are used for neuropathic pain and epilepsy elsewhere. Other medicines, and I don't know how much you've heard about low-dose naltrexone, but this seems to be something that we find is more and more promising. It helps address at very low doses, up to 5 milligrams. It addresses that neuroinflammatory change around the microglial cells in the central nervous system, and certainly seems to help in lots more ways, just not just the pain. It's an anti-opioid medicine, so it's not to be used with opioid medications, but we, as I'll explain in a minute, we don't like using those in fibromyalgia in general anyway. Its biggest issue is pretty safe at such low doses. People really don't have much, a little bit of nausea. Some people have reported nightmares, but in general, most people have no problem with it. The biggest issue is that because it's such a small dose, it has to be made up through a compounding pharmacy. But this is something that we're using more. Pramipexole sometimes gets used for restless legs and pain, and there are multiple supplements that people use. The one that I find most helpful is magnesium, which I think most people are across. Opioids are not recommended. There's no evidence to support their use. There's significant safety concerns, and they can actually contribute to the pain in some people, producing opioid hyperalgesic effects, which means that they can worsen the pain. Medical cannabis, we just don't have enough information to recommend it for fibromyalgia. The research that's been done in fibromyalgia, the trials are small, the number of participants is small, there's short treatment and follow-up durations. They're using different preparations in each different study. That said, there are people in the trials that derived a small amount of pain relief, and in a practical level, when people come to me and they're using medical cannabinoids, if it's helpful, they usually continue, and if it's not, they don't. And I think the side effects and the risks of the risks associated with use are significant. You also can't drive or operate machinery on some of the preparations. So they're not routinely recommended, but certainly there are people out there using them to help some of their fibromyalgia symptoms. You need to address all those coexisting conditions that can contribute to fibromyalgia type symptoms. So mood and anxiety we've discussed, inflammatory conditions, lupus, rheumatoid arthritis, other inflammation problems, endocrine disorders, diabetes, thyroid problems, those sorts of things. And perimenopause can contribute to some of the features that people are experiencing. Other causes of musculoskeletal pain, as I talked about before, such as osteoarthritis in the knees or elsewhere, irritable bowel syndrome, sleep disorders. Lots of people have problems with obstructive sleep apnea or restless legs or other sleep problems, and that can disrupt sleep and make fatigue worse. Migraine headaches need to be managed, and so does POTS. So there are all these other things that need expert contribution to managing, which can make some of the fibromyalgia features less problematic. When talking about brain fog and fatigue, which is what I wanted to wind up with, because I'm very conscious of the time, I'm sorry, Bella, more than 80% of people with fibromyalgia do experience fatigue and or brain fog. Sometimes these are the most debilitating symptoms for people. People can get through with their pain in whatever way they do that, but fatigue and brain fog are disabling. The causes are usually multifactorial, and I'll mention that next, but they also interact with each other. The effect of fatigue on effort is profound, and we know that particularly with the brain fog and the memory problems, there was some interesting research published about, I reckon it'll be about 10 years ago by Jacob Ablin's group, showing that the main features of fibrofog, so the difficulties with memory, attention, and information processing speed. The memory in particular, if there was increased effort directed towards, or increased concentration directed towards remembering things, the memory did improve back to near normal levels. So it's very dependent on how much effort is put in, and it's very hard to put effort into things if you're so exhausted. So they're sort of all interwoven. They fluctuate together with the other features of fibromyalgia. So if your pain's worse, all these other things are generally worse as well. And they do largely respond to those general management strategies. There's a few differences in there, and I'll talk to you about those. But it's important with the fatigue and brain fog to understand why they occur. So in general, there's that increased central sensitivity as part of all of this results in the fatigue and brain fog for all those. There's different central nervous system connectivity alterations, which result in difficulty with cognition, and all of those sort of abnormalities in the sympathetic nervous system, the HPA axis, and in the hippocampus that result in those profound levels of fatigue and difficulty thinking. But sleep problems like the obstructive sleep apnea or the periodic limb movement or whatever else is going on, that will contribute to poor sleep and therefore fatigue. Mood and anxiety, again, profound depression or anxiety do impact on your ability to think clearly, and also your ability to, your energy levels. Medications, which we'll discuss. Other illnesses, if you've got very active other types of inflammatory illness, that will profoundly worsen fatigue and brain fog. Deficiencies that cause fatigue, such as iron and thyroid, need to be replaced too. So all of those things are in the mix as to why we see fatigue and brain fog with fibromyalgia. And identifying the timing and patterns can give you a clue as to exactly what is influencing things in you. So what's going on as far as physical or psychological stress? Is there any change in management regimen? Maybe you've stopped something, maybe you've started something, maybe you're doing something different. Foods, some people will tell me, I've altered my diet, I've done this, I've done that, always hopefully under the guidance of a dietitian. The foods can have an impact on some people. People using a FODMAP diet, for instance, just really can change their symptoms. Allergies and can be to food and things, but also, allergies to other sort of environmental things can influence fatigue particularly, but also the way you think, and systemic illness activities. So, how bad is the rheumatoid arthritis, or are you having a flare of your scleroderma, or whatever's going on? All of that can influence. The medicines and brain fog fatigue, many of the medicines that people use can worsen these two features. So opioids and cannabinoids, again, not necessarily recommended, but many people do take them. Many antidepressants can worsen fatigue and brain fog, and medications used for sleep do the same thing, essentially by making people sleepy. The fibromyalgia-specific medicines, the NDEP, or amitriptyline, the duloxetine, which is known as Cymbalta, or other things, as well as the pregabalin or Lyrica, they can all contribute to fatigue. And so that's something to be watched. They might, and it's often a balance between, well, my pain has improved, but I'm more tired. So can we change the dose? Can we change the timing of the dose? Can we split things up? Can we, is there something we can work with? Some of the fibromyalgia-specific medication that is helpful, milnacipran. Again, it's a serotonin noradrenaline reuptake inhibitor, but because it's got more noradrenergic features it is more activating, and so there's less fatigue. Now it can have other problems. It can give you some palpitations and some jitteriness and things. So it's a bit of a trade-off, but it's certainly one of the ones that's more activating and less fatiguing. And low-dose naltrexone certainly has been something that seems to help both fatigue and brain fog. So fatigue and brain fog management, again, these same things coming up. So mindfulness, meditation, the mind-body practices are all terrific for brain fog and fatigue, and all the general sort of things that we talk about. So planning and pacing of activities, don't overdo it. Even on days you feel good, just don't go bull at a gate. Make sure you're pacing yourself so that you don't absolutely knock yourself out for the rest of the week. Hobbies and interests to distract yourself, and good old-fashioned sleep hygiene and things is important as well, just to get some proper sleep. So some regular gentle physical movement practice, again, like the exercise we talked about with the pain, but it doesn't matter when you're looking at improving fatigue and aiding sleep. It doesn't matter if you're doing what type of exercise, aerobic, flexibility, strength. It doesn't matter for how long. It doesn't matter for how intense you are, or whether it's land or water-based. It seems to improve fatigue and aid sleep regardless. So that's a little bit different to the pain exercise. All right, so Bella, I see you there. I'm finishing up. So I guess the bottom line is that fibromyalgia is really common. It's a debilitating condition, and it results from disordered processing of sensory information in the central nervous system. The symptoms fluctuate. They're worsened in situations of physical or psychological stress. The fatigue and brain fog are common, and they can be addressed specifically. And a proactive multidisciplinary approach to management is really important, because nothing works well by itself. And if you combine them and tailor them to the specific symptom profile, you end up with a better result. So thank you. Here's some places you can find some other information, and I'll let Bella talk to me about some of the questions. I saw that there's some flashing up there.
Thank you, Emma. That was incredible. And we're really grateful for how generous you've been with your time tonight. As you said, we've had lots of questions come through in the chat and in the Q&A. Many were answered throughout your slides, but I thought I'd pull out a few and just see if we could dig a bit deeper into them. So first one was, as consumers that are trying to take charge of their fibro journey, what would you suggest in terms of healthcare professionals that they should have in their toolkit? So would you suggest GPs, a specialist like yourself? Is there any others that you would suggest that we include?
So I'm a big advocate to have a broad network of supportive people. I like having someone who's your linchpin. Now, most of the times that's the GP that can help you address everything in a very straightforward manner, and the GPs are terrific at this. Nearly all the GPs that I know manage fibro really well. There's obviously differences out there, but they're fantastic. They can control and, I guess, channel referrals to other specialists as needed. So yes, you might need a rheumatologist initially to help with diagnosis, make sure that it's fibromyalgia is a standalone thing. Do you have something as well? Do you have ankylosing spondylitis as well? Do you have rheumatoid arthritis as well? Is it just the fibro? Sometimes a sleep physician, psychiatrist, all of these different people, according to, the different sort of, I guess, symptom profiles, they need to be sort of, I guess, there needs to be someone managing that, and a GP is in a good position. It's, I feel, essential to have some guidance with your physical therapies, at least to begin with. So having someone who can help you with that, whether it's a physio or an exercise physiologist, or someone who can help you with your gentle movement initially, whether you keep going with them or not, it's a different question, but generally having someone who understands pain and having someone who understands the sort of movement that you need to do, rather than, full-on sports training or whatever. I think someone who's across that, having a counsellor or a psychologist, someone that you also have in your corner that you can discuss You can discuss straightforward pain management strategies with them. What do I do when I've got a big week at work and I'm having a flare? What are some strategies? What do I do when this happens? What do I do with that? That sort of stuff. Or you can talk about all of those other things that are stressing you, but having someone in your corner rather than talking to family members or the neighbour or whatever, do all that too, but having someone that is there to do that particular job is really helpful. Other therapists as you see fit, gentle yoga, great. Have a yoga session, have a myotherapist, have whoever you need in your corner, have them there if you can, but have someone sort of coordinating, I suppose, is my only suggestion.
Thank you. That's really practical for us consumers to take away. Our next one is, you mentioned the correlation between sleep and fibromyalgia. Why is sleep health so important?
Okay, so sleep in general is important, which we all know. And I guess with fibromyalgia, you're up against it a bit anyway. As I said before, some of those central nervous system changes occur to not let you down into those deep layers of restorative sleep. Now, your body does need good quality sleep in order to stay well. And so giving yourself the best chance of achieving reasonable sleep is essential. So all of those sleep hygiene things that are important that people will talk about, and I won't list them all, but there's lots of things on the list that you can do. Just every little bit helps. The sleep itself is an issue, but then the sleep has an overflow effect on fatigue and an overflow effect on brain fog. And so it's not just sleep and not feeling refreshed. There's all of these other aspects that are influenced by it as well. So it's a real linchpin.
Thank you. Going on to another practical strategies one, what strategies have you seen that consumers find helpful to navigate the embarrassment or stigma associated with some of the brain fog?
Yeah, that's a good one, and I think it's people approach this different ways. So there are certainly people who will talk to the people around them, talk to their workplace about their diagnosis and about what that entails and how the brain fog can be worse some days and better other days. And there's a good reason for that. It's not a cognitive decline. There's no baseline decline. People are as intelligent as they were last week, last month, last year. It's just how accessible those brain functions are. So strategies around that, I think, are how comfortable you are to discuss it first up. There are lots of people doing lots of different things, but I think the best one is getting that gentle exercise earlier in your day, going for a little walk to try and sort of make that stimulus sort of occur earlier. Oh, hello. Occur earlier, and so therefore you can go into your job or go into your uni or whatever you're doing with that sort of little burst of refreshment. Give yourself lots of breaks, use aid memoirs, all of those sorts of things, but don't shy away from it and pretend it's not happening, because I think that compounds the issue. I think talking to trusted people is the best strategy that I can find. It takes the stress out of it.
Thank you, Emma, and thank you for a fantastic webinar this evening. I know I definitely learned a lot throughout it. I'm sure everyone did as well. There was a lot of questions that came through, so if your question wasn't answered, keep your eye on the Rattler, our newsletter, and we'll be doing a series with everyone's questions so that we can keep getting them answered for us all. The on-demand recording will be available in a few days, and they're always available on our YouTube channel. So jump on there and see if there's any other webinars you've missed recently. Have a watch of those. Apart from that, on behalf of MHA, I want to say thank you for joining us tonight. Thank you, Emma, for your generous time and sharing all of that valuable information for us. And we look forward to seeing everyone at our next webinar soon.